1C. It is discuss cardiac output, stroke volume, heart rate, and clinical variables that influence these. Discuss the clinical measurement of cardiac output, cardiac index, heart rate, stroke volume, preload, afterload, contractility, rhythm, systemic vascular resistance, pulmonary vascular resistance, and normal and abnormal clinical situations, and discuss hemodynamic monitoring in detail.
All in 10 minutes.
All in 10 minutes. Okay. So today we're going to discuss what these factors are and what they mean in terms of mechanical properties of the heart. So the heart generates a cardiac output in order to accomplish two things. We're trying to oxygenate our tissues and clear metabolic waste. There are three main things that we need to consider in terms of cardiac mechanics. The first is that blood flows due to a pressure gradient. The second is that pressure is determined by the volume in a chamber and also the compliance of the chamber wall. And the third is that volume is determined by the net amount of blood entering versus leaving a chamber. So let's dive in and talk about these properties. First, we're going to talk about cardiac output. Cardiac output is the amount of blood that leaves the heart in 1 minute. It can be determined by the equation stroke volume times heart rate, and normal is approximately 5 to 6 liters per minute. If we wanted to determine the heart's performance in terms of body size, we can calculate a cardiac index. This is just cardiac output divided by our body surface area, and normal is 3 to 4 liters per minute per meter squared. So what are the mechanisms that allow for cardiac output to change? Well, we've said that cardiac output is influenced by the variables of heart rate and stroke volume. Heart rate is an autonomic driven response, and normal is 60 to 100 beats per minute. We know that increases in heart rate are due to sympathetic nervous system stimulation and are due to norepi on beta-1 receptors. Decreases in heart rate are due to parasympathetic nervous system stimulation and are due to acetylcholine on muscarinic receptors. Stroke volume is influenced by two separate variables, end diastolic volume and end systolic volume. To come up with stroke volume, we just need the difference between these two. So this is just end diastolic volume minus end systolic volume, and normal is 50 to 110 mLs per beat. So let's look at these more closely. End diastolic volume is the amount of volume left in the left ventricle at the end of diastole, or right before systole. It is influenced by filling pressures and by compliance. So end diastolic volume is often associated with the word preload. And although these two terms have a relationship, it's important to note that they're two separate concepts. End diastolic volume is the actual amount of volume in the left ventricle at the end of diastole, whereas preload refers to the stretch or the left ventricular wall stress at the end of diastole. The more volume that's in the chamber, the bigger the stretch of the sarcomeres. That allows for greater actin and myosin cross-bridging, which increases calcium channel conductance. This increase in calcium increases contractility, which increases our stroke volume. So this is known as the Frank-Starling law. As an example, if we give a bolus of IV fluids, then we are going to increase our preload due to increased filling. This increases our stroke volume while maintaining end systolic volume. On the opposite side, if we give a medication such as Lasix or nitroglycerin, we're going to decrease our end diastolic volume by decreasing filling. This decreases our stroke volume and maintains our end systolic volume. Now let's talk about end systolic volume. End systolic volume is influenced by afterload and contractility. Afterload is the resistance that the heart has to overcome in order to eject its stroke volume. It's most influenced by systemic vascular resistance or arteriolar tone, but it can also be affected more proximally in the heart with conditions such as hypertrophic cardiomyopathy or aortic stenosis. If we give a medication such as phenylephrine, we're going to increase our SVR. This increase in afterload decreases the heart's ability to completely eject its stroke volume. So our stroke volume is going to be decreased and our heart's going to remain full. So our end diastolic volume and our end systolic volume are going to increase. If we give a medication such as nitroprusside, which is a potent vasodilator, we're going to decrease our SVR. This decrease in afterload is going to result in the heart being more able to completely empty. So our stroke volume is going to increase and our end diastolic and end systolic volume are going to decrease. So to calculate SVR, we can use the formula MAP minus CVP divided by cardiac output times 80. And 80 is just a conversion factor because we're using different units. And normal is 800 to 1500 dynes per second per centimeter to the negative fifth power. And to calculate PVR, we actually use the exact same formula, but now we're subbing in pulmonary pressures. So we're going to do mean pulmonary arterial pressure minus pulmonary artery occlusive pressure divided by cardiac output times 80. And pulmonary vascular resistance is a lot less than SVR, so it's going to be 150 to 250. So now let's move on to contractility. Contractility is the intrinsic ability for the heart to squeeze. The ability for the left ventricle to generate a pressure in order to eject its stroke volume is the intrinsic inotropic state of the heart. Contractility can be assessed clinically through ejection fraction. Ejection fraction is calculated by taking your stroke volume, dividing it by end diastolic volume, and normal is about 60%. It's important to note that contractility is independent of preload and afterload, and it's influenced by chemicals such as calcium. If we give a medication such as milrinone, for example, milrinone is going to inhibit phosphodiesterase, which will increase our CAMP. That increases calcium availability, which will increase our contractility and increase stroke volume. If we give a medication such as metoprolol, we're going to decrease CAMP, decrease calcium, and decrease our force of contraction, which will decrease stroke volume. So now that we've covered cardiac mechanics, let's move on to hemodynamics. Hemodynamic monitoring is an important part of patient evaluation, and the risks need to be weighed amongst the benefits. Invasive arterial blood pressure monitoring is considered gold standard for cardiac patients, and our MAP is the most useful indicator for assessing end organ function. MAP is calculated by taking our systolic blood pressure and adding that 2 times diastolic blood pressure divided by 3. And normal is 65 to 110 millimeters of mercury. Invasive arterial blood pressure monitoring is useful for when you need real-time assessment of perfusion pressure and frequent blood sampling. Also, the arterial blood pressure waveform can tell you a lot about what's happening in the heart. So if we look at our arterial blood pressure waveform over time, we can assess cardiac function. So the upstroke is indicative of contractility. The peak is going to represent our systolic blood pressure. As the left ventricle starts to relax, we're going to get a downstroke, and eventually the aortic pressure is going to exceed the left ventricular pressure, so the aortic valve is going to close, and that's a marker of the dicrotic notch. And then we get our diastolic blood pressure. To get our perfusion pressure, we subtract the systolic blood pressure from the diastolic blood pressure, and the area under the curve represents our stroke volume. We can also assess fluid status by looking at the arterial blood pressure waveform through systolic pressure variation. Systolic pressure variation looks at the change in systolic pressure up plus the change in systolic pressure down. In a normal patient, systolic pressure variation is about 7, in a mechanically ventilated patient, it's 7 to 10 millimeters per mercury. And hypovolemia significantly increases systolic pressure variation. We say that increases greater than 10 usually indicate the need for fluid, and there's usually a greater down change. So now let's talk about CVP. CVP also is a good monitor for volume status and cardiac function. It's a function of intravascular volume, venous tone, and right ventricular compliance. Normal CVP is 1 to 10 millimeters of mercury. And we can use the CVP waveform, like Carlos mentioned, to assess what's happening in the right atrium. So if we align it with an EKG waveform, we can see what's happening in the heart. So the CVP waveform has 3 peaks and 2 troughs. The first peak is designated by the letter A, which stands for atrial contraction. So this is going to follow our P wave. The second is the letter C, which represents tricuspid valve elevation into the right atrium or a right ventricular contraction. So this follows our QRS complex. Then our right atria start to relax, so we start to decrease pressure. And this is our X descent. This is going to align with our ST interval. Then we start to have passive filling of the right atrium again, and this is our V wave, which will follow our T wave. Then the right atrium is going to empty through the tricuspid valve into the right ventricle, which will decrease pressure and cause our Y descent. So we can tell a lot about cardiac pathology based on our CVP waveform. The first is the loss of an A wave. A wave is atrial contraction, so conditions that cause unsynchronized atrial contraction are going to cause our loss of an A wave. So that would be AFib. Also, patients who might be V-paced and have an underlying rhythm of asystole might also not have an A wave. We might have a canon A wave if our right atrium tries to contract against high resistance. This can be because of a stenotic valve, like tricuspid stenosis, or because we have a non-compliant ventricle, so right ventricular hypertrophy. And then third is our V wave. V wave signifies passive right atrial filling. So if we have increased volume and pressure during passive filling, that could be the result of tricuspid valve regurgitation, because while you have right ventricular contraction, you start to get backflow into the right atrium, which is going to increase volume and pressure.
So you mentioned stroke volume variation, and you mentioned greater than 10 would be hypovolemia. Can you explain why you have a greater than 10?
For stroke, for systolic pressure variation greater than 10? In a controlled environment, so a patient who's mechanically ventilated, you're going to have the positive pressure on inspiration and expiration. And so there is variation in that, and when we look at our systolic pressure variation, we're looking at it at the end of end expiration.
So that's what it is, but
Yeah.
why is it bigger with hypovolemia?
I would say with hypovolemia, in a patient who, so we have this variation. In a patient who is inspiring, there's usually fluid that is in the pulmonary vasculature, and because you are increasing volume, you're decreasing your pressure, so that volume stays stagnant in the pulmonary vasculature, and then during expiration, that pressure brings it forward and shunts it to the left side of the heart. So if you have fluid depletion, you might not have as much fluid returning to the heart, so you could have a difference in your systole.
So think about you guys as, yeah, look at Starling's law, look at the curve. So what happens is now you're getting bigger variations of that. You have increased pressure in there, so what is that doing to what's returning to that side? So it's basically like giving somebody a diuretic, right? You're gonna decrease your area under the curve, your stroke volume goes down. What happens with hypovolemia? You get a smaller stroke volume, right? Now what happens, you increase the intrathoracic pressure even more, what is that gonna happen? You're gonna have a bigger variation in that. One other is, you did a really good job talking about stroke volume over there. So what would be the difference, now let's take it to some pathology. Let's look at heart failure. Now talk to us about what you would expect, or where with diastolic failure versus systolic failure.
So, we have two separate types of heart failure. The first is, like you said, systolic, and the second is diastolic. The problem with systolic heart failure is that you have an increase in filling and you're unable to eject that blood. So what you're gonna see is, like for example, dilated cardiomyopathy. The heart is able to fill completely, but you have stretched out your ventricle, so you've gone past the Frank-Starling mechanism. So now you need possibly an inotrope to eject that blood in order to generate an appropriate stroke volume. With diastolic heart failure, you have issues such as a non-compliant ventricle. You're unable to fill the ventricle. So this would be like hypertrophic cardiomyopathy, obstructive cardiomyopathy. So because you have hypertrophy in a non-compliant ventricle, you're not able to fill it as much, and in this situation, you also have some increased afterload, so you're not able to eject it as well. So in this situation, you would want to increase filling, so you have more, that's the Frank-Starling mechanism, have more to fill, to stretch the sarcomeres, and you also want to decrease the afterload to get that out as well.